Good afternoon. My name is Kamiljan Akramov. I'm a senior research fellow at the International Food Policy Research Institute. Welcome to today's webinar. Today's webinar on armed conflict and immunization coverage. We are lucky to have Dr. Olga Shemyakina. She is an associate professor at the School of Economics at Georgia Institute of Technology. Olga's research examines the effects of conflict on economic and political stability and on the behavior of households in various geographical and institutional settings. Dr. Shemyakina received her PhD in economics from the University of Southern California, Los Angeles in 2007 and joined Georgia Tech in August 2007. Olga's research interests include applied microeconomics, development economics, labor economics, conflict, health, education, and gender. Olga did research together with IFPRI researchers on land and land reform and household welfare in Central Asia, including in Kyrgyzstan. Today's presentation is on armed conflict and immunization coverage. We have also Rui Dang. Rui Dang is a senior lecturer at the Westminster International University in Tashkent. He will give his thoughts about this presentation after Olga's time. So Olga, you will have about 35-40 minutes for the presentation. And then I will invite Dr. Rui for his points. So let me now give the floor to Dr. Olga Shemyakina. Olga, please, floor is yours.
Yeah, thank you so much, Kamiljan, for inviting me to give a seminar. And I know it's like the last seminar, like midsummer. So thank you for coming. This paper is looks at currently important and on the news issues such as vaccination. And this paper is with researchers from PRIO, Peace Research Institute in Norway, Gudrun Osby, Andreas Fora Tøllersten, Henrik Kurdal, and Marijke Verputten, who is in Belgium, University of Flanders. So, there are many, we are aware, right, that there is an armed conflict around the globe, and armed conflict happens to a different degree at different times. And one of the major issues is, people die, and there is a lot of increase in diseases during conflict, and in particularly in vaccine preventable diseases, because populations change, they migrate, there is decrease in health coverage. People migrate, go through areas where they haven't been before, and they encounter these diseases. This kind of exposure to diseases contributes to mortality, and in particular mortality among children under 5 years of age, who are the most vulnerable because the immune system is still building up. So, and immunization ranks among the most cost-effective measures to reduce child mortality in low-income countries, according to WHO, UNICEF, and the World Bank. So in the past, the supply immunization has increased dramatically, and that increase contributed significantly to decline in mortality rate due to vaccine preventable diseases. However, we all know that although vaccination is available, the uptake or demand for it may be low, and we'll discuss the reasons why it could be the case. And people procrastinate, they are sensitive in terms of what we have to pay for vaccination. Since it's a preventative measure, they may not be able or willing to cover the cost. And people know, I mean, kind of like the issue with prevention is that like you have to pay upfront in order to defray the potential cost in the future that may or may not happen. And because of that, many people like we don't absorb that cost yet, or may never absorb it even if they don't immunize. And as a result, like, there is less demand for vaccination. So looking at the extent of conflict, this is a map for conflict-affected countries in and exposed areas in sub-Saharan Africa. And here you have like just giving you a broad picture of the countries involved and events experienced. Like the large percentage of population is exposed to conflict, about 31% of total population. And 31% of total population lived within 50 kilometers of one or more of violent events during a conflict. So, and you could see that coverage of countries differs in terms of the country may be in conflict, but events that happen there may affect only parts of the country. So in this paper, we look at the countries that were impacted by armed conflict, and we look at the kind of local events, how they impact child immunization. For example, if you look at one of the blue dots, this is just an example. These are not necessarily the countries that we study here because it's just 2015. Children who live within 25 kilometers of a conflict event during the first year of life. And I'll tell why it is important. So the prior literature on conflict and public health or child health within economics and kind of economics and political science domain falls into largely exposure to conflict in utero and or childhood effects. So when children are exposed to conflict in utero, it means that their birth weight it will be impacted. There are several studies on that. And when children are exposed in utero or in early childhood between the time of their birth and age 5, where anthropometric scores such as height for age scores may be impacted negatively. So like they will be shorter on average when children who didn't experience the conflict. And those effects, they translate into later adulthood because those children grow into adults who are a little bit shorter. They receive less education because they go to school at a later age, but they may leave earlier because they reach age when you leave school traditionally in particular country. And there is some research that shows that it may impact also some cognitive and non-cognitive skills. Now, what are the mechanisms behind maternal stress, in particular for that impacts birth weight? There could be destruction of crops and income sources, access to food, increase in disease and malnourishment, and that impacts your child anthropometric scores. They are shorter on average because nutrition is not coming, or it's coming at like various intervals that are not conducive to consistent growth. So we look at the supply of vaccination under conflict and demand for vaccination under conflict next. So the supply of vaccination under conflict kind of falls under more like mechanical issues or disruption associated with conflict effects in the country. So there could be financial challenges, right? Decline in funds for vaccination available because a lot of money goes to fight the war effort, to kind of for more immediate needs, so less for preventative issues. Infrastructure may be damaged. And this damage to infrastructure creates a lot of logistical challenges that is called chain disruption, because it's hard to transport vaccine safely without refrigeration. Quality of storage facilities will be compromised, very likely. And it's harder to establish and manage vaccination sites because it's, there are safety issues in the country, so you have to take more care in where and when you establish those. And when delivery issues, right, like vaccination or displacement camps, there could be also shock to vaccination personnel. There could be overall lack of personnel due to studies found that people, it could be there are strikes by health personnel, they affect children, or safety of workers can be compromised, so less people want to work in this occupation. While when we look at the demand for vaccination under conflict, there are impacts more associated with kind of decision-making by population. And when caregivers for children, because children have to be brought for vaccination, it's not their choice to get it, it's their caregivers, and caregivers decide on when and whether children get vaccinated. And it has been found that caregivers in more conflict-affected areas are less likely to accept vaccination for children because then have mistrust in authorities. And that there is a common history, especially in some of the African countries, where there is a mistrust in programs provided by certain groups. Also, there could be mistrust in the services provided by, let's say, winning side of a conflict, if in the areas that previously were controlled by opposition. There is mistrust also related to long-term impacts of Western colonization. And there is a lot of rumors related to vaccine, kind of deliberate. And people say that vaccine could be used for sterilization, deliberate HIV infection, could be chemically contaminated. And those rumors may ring a bell now, right? So fake news. Campaigns, they were common before they became commonly used on. So, and caregivers who were of conflict are less inclined to demand vaccination because they could be fearing transporting their children in a particular locations because, for example, in Philippines, they found that probability of mother taking children for vaccination or to health facility are lower if they live in conflict-affected areas because there are higher costs of traveling. Also, population is displaced, can be displaced under conflict, and it creates twofold effect on demand for vaccination. Short term, in displacement camps, actually the cost of vaccination could be lower per person because there is a greater concentration of population that need coverage. And also people don't need to travel as much. However, in the long term, if people displace and they don't necessarily live in displacement camp or live elsewhere, it takes them harder kind of to get into the system and get access to medical services because there could be also reluctance by the refugee receiving population in order kind of to incorporate them into the general system of access to services that has happened before in multiple countries. It happens with education, because there is an expectation long-term that refugees will go back. Can I just check? Do you hear me well?
Yes, yes.
Yes, we can hear you well.
Okay, good. Thank
Yeah,
you.
if you, Olga, if you can speak up a little bit, that
Sure,
will be
I will. Yeah.
even better. Okay.
So the research question that we address in this paper is whether and to what extent local and country level exposures to armed conflict affects age-appropriate immunization coverage. And in overall, the straightforward impact of conflict on immunization is not very clear. On one side, we do expect that a lot of disruptions, mechanical disruptions of supply chain, and also disruptions due to kind of perception of a caregivers and increased costs related to travel will negatively impact age-appropriate immunization. However, it may also happen that in the case of vaccination campaigns, the non-governmental organizations and governments review these displacement camps and refugee communities as an opportunity to increase vaccination there. And actually, vaccination rates may go up. So in this data that we use for this paper, we combine detailed georeference, individual level, age-specific data on immunization from demographic and health surveys. These are very big, large data sets, and they are highly regarded, they are high-quality data set. And we combine it also with highly regarded, highly used data on conflict events and fatalities from UCDP PRIO database. And the base list of conflicts and years by acute was constructed by Gledich and Kaufers in 2002. And we do not distinguish conflicts that by type, civil or ethnic. Okay, and we have information on latitude and longitude and radius in kilometers of the area affected by conflict. So we looked at the countries in sub-Saharan Africa for which demographic and health surveys rounds had georeferenced information. And we pulled data of these countries of 69 surveys from 51 countries conducted between 1990 and 2013. In each survey round, the respondents are part of a sample that is nationally representative and geographically stratified based on survey clusters. So our main dependent variable is child vaccination, full child vaccination. This variable is defined at the child level for children age 1 to 5 years or 12 to 59 months. So 59 months is just short of half year. And we use as an independent variable number of conflict events that occurred in the first 12 months of a child's life. So it's a child born in February 2009. We're looking for the next 12 months, the conflict events that happen around locality where the child was born, within 25 kilometers. So we count these events and come up with an aggregate measure. And when we matched this measure to DHS survey clusters. Okay, so, and those clusters correspond to villages and in rural areas and city blocks in urban areas. So what we try to do here is to find a good counterfactual. What would the vaccination rate have been in the absence of conflict? So one option would be compare the levels, looking at the children in affected and non-affected regions. That's commonly done. However, that technique is hard to justify because conflict is not random. For a while, like we kind of treated conflict as random, but it's not necessarily so because there are conditions that are leading to it. And those regions that impacted and not impacted by conflict are different. We can also compare trends in vaccination rates across affected and non-affected classes. They may in fact, reveal more of what is happening. However, we also have challenges that because we expect that the trends to be similar across those regions in the absence of conflict. However, you do need kind of pre-conflict data also to show that those regions will be on the same trend, because the clusters could be different due to, let's say, economic decline. One region could be more prone to conflict and also may not have enough health infrastructure. So as a result, we look at the children within the same cluster, but of different age. So you have child, let's say of age 2, who has been exposed to conflict when she was 0 to 12 months old. And then we have children, let's say age 3, who were not exposed to conflict during that critical age, 0 to 12 months old, but they live in the same kind of sub-geographical area, but they were not exposed. And that matters because that window is crucial for providing vaccination. And we use the strategy to get around those indigeneity issues. We're looking at within cluster. And within cluster meaning that we're looking at a particular village or city block, and they're looking children of varying age within those samples. One of the main ideas that we exploit are facts that immunization, routine vaccinations, they happen typically in the first year of life. So we focus on 7 vaccines, and here we have vaccination schedule as recommended by the WHO for African countries. So we have 1 vaccination against tuberculosis or BCG recommended at birth, 4 oral polio vaccinations recommended at birth, 6 weeks, 10 weeks, and 14 weeks. 3 vaccinations against diphtheria, pertussis, and tetanus recommended at 6, 10, and 14 weeks, and 1 vaccination against measles. So all of those vaccinations, except measles, typically happen within the data shows that all of those vaccinations happen within the first year of life, while measles kind of continues. And we focus on those 7 vaccines. We consider them for complete immunization rate, or like 0 to 1 variable, a dummy variable. Vaccination against tuberculosis, 3 oral polio vaccinations, each 1, so spread out. So we want to focus on those that clustered around age before child reaches age 1. So, and if you could see is this is figure 1 again. So here we have rates for different vaccination. And you could see that the rates increase for different, for children as they grow. And once children reach age 12, they flatten. So there is kind of a rapid increase in vaccination. And then we have kind of a decline. not a decline, sorry, like a decline in increase. So it's like flattens out. And if you're looking at the complete immunization rate, which is if a child has received all 7 vaccines, it's the bottom line because it's an aggregate measure. And you could see that it's kind of has a decreasing slope to an extent with respect to age, which shows that over the time, vaccination campaigns by WHO have been, and countries involved have been successful. So younger children have better vaccination rates. Okay. So and that flattening shows us that all children who are age 2, 3, and 4, are basically older than 12 months of age, and that live in the same DHS cluster, who were not exposed to violence in their first year, should have very similar vaccination rates. So you see like age 24 months, 36 months, and 48 months. They're kind of like similar to each other. So that's what we use like here. So our identification strategy is based on vaccination data. And it full immunization variable, which is our main dependent variable, takes a value 1. If 1 to 5-year-old received all 7 vaccines and is 0 otherwise. This vaccination data is based on MAVA's recall and availability of vaccination card or another document. So on an average, children received about 4.6 of 7 vaccines considered, or 65.6 coverage rate for the vaccines. And 41% of all children received all 7 vaccinations. And conditional vaccination being reported, about 45% receive a record of vaccination history. We also did supplemental analysis looking at the correlation between having a vaccination card and our independent variables, and we do not find much of a relationship there, so we do not see selection bias. So this is our one of the first tables. Here we look at the impact of conflict events in the first life year of child within the radius of 25 kilometers. So what we see here, like the first line, it's a lot of zeros. It shows that conflict events in the first 5 years do not seem to impact his or her vaccination rate. We also control for a variety of additional characteristics, such as child age in months, and birth month fixed effects, controlling for seasonality, child being a girl, birth order, and a set of MAVA characteristics and household characteristics in column 4. We also control for polygamy, and you could see that the more characteristics we add, the lower is the smaller is our sample, because not all children have information on those characteristics for them. But we also see that most of the covariates, they have an expected sign. Children of older MAVAs and also MAVAs with more education are more likely to have been vaccinated. MAVAs that have total more children born, less likely to be vaccinated. Also interesting that MAVA ever have terminated a pregnancy is positively associated with a vaccination rate, and we believe it is a proxy for, healthcare access. Right? And you see household assets positively impact vaccination, and being polygamy, mass household declines vaccination. So this absence of effect of conflict could be related to an aid response and mobilization of medical resources in response to conflict, but it could be related to the fact that WHO and the governments have established infrastructure in those regions, like at least basic infrastructure. When we look at the intensity of conflict, not just the count of conflict-related events, but also the number of people died, fatalities associated with war. And here we see much more kind of sizable and negative impact of conflict on child health measured by immunization. So for each 100 deaths, the coefficient declines by point, vaccination declines by 0.003. So this is still a fairly small effect, but it looks sizable and significant and stable across the estimation. So given that, it kind of motivated us to look at the conflict intensity because there could be different institutional reasons for why we observe this conflict intensity impact. So we look at the minor conflicts and major conflicts based on the number of battle deaths, and we also control for regional level or child level impact of conflict, and also for country level impact of conflict. So here, looking at the minor, major conflict, and we add here conflict events in the first life within 25-kilometer radius, average at the country level, meaning that even if you're a kid who lived in the conflict after a year, but not close to the conflict event, you can still be impacted because there could be decline overall in the resources for medicine during that year. And you could see that for major conflict, there is a negative impact of conflict events, while for minor, we have positive and strong impact. And when we're looking at kind of average country level impacts, those are observed primarily for major conflict. It looks like when the conflict is large, you see negative and substantial impacts on child immunization. We also use an alternative measure of conflict, looking at the share of country grids impacted by conflict, and we see kind of more similar, consistent negative impact over major conflict, and again, no impact for the minor conflict. So given that, we also estimate table that looks at the interaction between coefficients, looks at the pool data, and we do interactions between major conflict and conflict events. And the first year of child's life, what do we find here is that the major conflict has a sizable negative impact on child health. And also at the country level as well. So like we have really similar impacts when we look at the pooled sample, but we prefer kind of to deal with parsimonious specification between minor and major conflicts and dealing with them separately as we go. One of the channels that we explore is refugee camps, because we mentioned that refugee camps may be places where medical care is accessible, and in particular vaccination, and they could be used as a way to deliver resources. And we explored information on the location of refugee camps, centers, and IDP settlements. Camps were established within 12 months before child was born, and And this variable accounts for the likelihood that there is a lag in the establishment of health service provisions following the arrival of migrants to an area. The longer the camp has been in operation, the more services are likely to have been established. So it takes a bit of time to establish the services, and we expect that children being receiving this beneficial impact from services as the camp is being established. And so we would have expected that if location that hosts refugees attracts more health supplies, and if this potential access to resources drives the positive impact in the case of minor conflict, we should expect that the refugee camps channel will reduce that impact. And surprisingly, we find that no impact where refugee camps, we do have positive impact on vaccination, but not statistically significant in the case of minor conflicts. But in the case of major conflicts, refugee camps, actually all kinds of camps together, because only kind of 8% of children are impacted by being close to a camp. So like that's a combined impact and gives us more power. It's decreasing the negative impact of a major conflict on vaccination. Okay. We also look at different robustness checks, like looking at the impact of non-migrants, because there is a lot of migration or displacement during the conflict. And unfortunately, we can't do very detailed analysis using DHS data for that. We also change the distance of how we measure the conflict. And the basic result is closer distance is more important. Looking at the conflict 1 year prior and 1 year after the child was born. So shows that conflict in the first year of child's life is more impactful for his or her vaccination rate. And we're looking at the different models. Let's look at the first three. Here we examine the impact of conflict on non-migrant subsample. And we repeat models in tables 2, 3, and 4. And what we find that the impacts are pretty much similar to what we have found before. So conflict events in the first life. Here we do not impact children's immunization for the full sample. Conflict deaths in the first life year negatively impact child's immunization, and minor and major conflict we seem full with similar patterns. Suggesting that possibly when migrants have been affected in a similar way as non-migrants, because we don't see much of a change here. So the impact of conflict within 50-kilometer radius of child's cluster of residence has a basically we change the distance. We now and we change the distance and we include a broader radius for events. And we could see that like more events we include, actually there is a decline in the impact of these events on the children, which means that like the closer the events are, the more impactful they are for the child's vaccination rate, right? Like, which is, we would have expected that regardless, but at the country level, the effect, I mean, it's also substantial. It's statistically significant, but it's about half the size. So we also include here in table 8 variable for conflict events before the child was born, because like you could see like are there any additional impacts, maybe like there is a cumulative impact of events and it impacts child immunization, not just access to immunization services within 12 months. And we find that this variable actually has pretty much zero impact, except for example, with small negative impact on immunization, and it doesn't really impact all other models substantially. So, I mean, although there could be lagged effects as supported in column 6 and positive impacts if a battle deaths in column 2. So the conclusion is that conflict intensity appears to have a negative impact on full immunization within a cluster of birth across the country during the first year of child's life and under a major conflict. And it is possible that increased development services and healthcare delivery in affected regions and around refugee camps may have led to high immunization, which we see for major conflict happening. So, however, minor conflict results show us that technically there is no impact, no to positive impact of conflict for minor conflicts, meaning that child immunization actually may increase during a minor conflict, suggesting that provision of services works well. So that concludes my presentation, and I would like to say that we are not trying kind of to do an average impact of conflict, but we are trying to see what are the trends if we were to apply the strategy to a variety of countries and examine the patterns in immunization with respect to variation and conflict within child's locality of birth. And we do understand that each conflict is different. However, we want to kind of examine more countries overall together and look at the trends between them. So thank you for your time. And let me know if you have questions.
Thank you very much, Olga, for a very interesting presentation. And now I would like to invite Dr. Dang. Dr. Dang is a senior lecturer in economics at the Westminster International University in Tashkent. And he has a PhD in economics from Ruhr University in Germany. And Dr. Dang also has a postdoctoral training from Dartmouth College in USA. So Dr. Dang, you have about 5 to 7 minutes for discussion. Please. You are muted. Can you unmute yourself?
Yeah.
Okay. Now.
Okay, thank you. So let me first share the slides. Okay. So it's my great pleasure to be, invited to discuss such a fantastic paper with, innovative conclusions that may have policy implications. So first, I have to mention that it is my first time to discuss a paper that based on the context of, lower middle income countries. Okay, so my background knowledge is had been highly expanded through reading this paper. Okay, so here is outline, summary comments and some, humble suggestions. Okay, so summary, we will quickly go through it. So this manuscript studies how armed conflicts impacts immunization rates among children. So it combines two large data sets, which is quite unique. Okay. Okay, so we quickly go through. So we go to the third. So the important results, which is also quite interesting, is that the paper suggests a non-monotonic effects on vaccination rate, with minor conflicts being associated with higher full immunization rates. So which is yes, so which could be, I think personally, could be further explorable in the future research, and could give, could assist for the NGOs and also for the national governments or subnational governments to make more precise, policy towards increasing the vaccination rates in these regions, influenced by the let's say the minor conflict regions. Okay, so the estimation. So basically, the author use a simple linear probability model with robustness checks, and he especially uses controlling for land conflicts and also one of the robustness procedures. Okay, so data source is quite unique. So DHS demography and health surveys, which is my first time to, to explore this data. I mean, with details. Okay, together with the Uppsala conflict data program, geographic reference data sets. Yes, that's quite because I got my master's degree from Uppsala University. Yes, it's yes, they have a quite strong, research department for peace and conflict research. Yes, so basically the data has a high number of, individuals and observations belong to, 13,772 clusters. Okay, so here one comment is that I still am not quite familiar with how the clusters are defined within DHS. I guess for most of researchers who never be, be exposed to DHS survey before, I mean, maybe the author may think of and one or two sentences to explain how the clusters are defined. Okay, so basically the dependent variables are generally fully immunization rates based on 7 vaccinations received by children. Okay, and also share of 7 vaccinations received by children at the national cluster level. So independent variables, including conflicts variables, children variables, mother and hospital variables, and also the refugee camps is also important control, because, as also mentioned, the refugee camps might improve the the access of healthcare supplies, for the residents within the refugee camps, and also, of course, IDP as well. Okay, so here, this is the main identification. Okay, so I will not explain to save time. So here, I think there are general, strengths. The data sources are quite unique, and also, the paper is well written and it's relatively easy to follow, even for non-experts like me. Okay, so there are definitely unique contribution to the literature, and also there could be potential contribution to policy practice in future for UNICEF, for WHO, for national and subnational governments, and also for Gavi, if you realize that. Okay, so there are some further concerns. So first is in table 23, there is a variable mother every terminated a pregnancy. So if you read the table, you will find that after include some more controls, the direction of the effects of this variable became, from negative to positive, and also become statistically less insignificant. Okay, so there might be some explanation, because I didn't find potential explanation of this variable. Okay. So the second thing is that I'm not quite sure how the authors tried with multinomial logit and probability regression, because, for example, another way to make more deeper analysis is that to include the partial vaccination into the independent variable. Okay, so maybe you can say the not vaccinated means 0, partial vaccination means is 1, or full vaccination is 2. Okay, so maybe there will be some more interesting stories if if the multinomial logit probability regression would be applied to make some analysis. Okay, so there are some concerns. So the most tricky concern for this research paper is that the causal relationship is still not clear. So after you have the authors have made, let's say, extensive analysis on the identification assumptions, still it is clear that there is some associations, but these identification assumptions are not, strong enough to convince the readers or maybe referees about the causal relationships. So which means the ground for any policy suggestions are not strong enough. Yes, it depends on the literature, because if in the economics literature, the causal relationship is quite important. But if they also focus on political science literatures, for example, or health policy literatures, or development policy literatures, I mean, it's, these journals, maybe they have less strict requirements on the causal relationships. Yes, I'm not very sure about that. Okay, but still, it's a pretty nice way, for the author to think of, to gradually to, what should I say, to improve the identification assumptions in order to make the analysis more convincing, and in order to, to try to establish the relationship between conflicts level and vaccination rate and the national and subnational level in the countries which are influenced by different types of conflicts. Okay, so here, what I think. So of course, the scope of the manuscript may benefit from further, by adding analysis on healthcare expenditure or health aid received at national or subnational level, because the main indicators, I mean, from economics perspective, the main, control variable for healthcare supply is, the healthcare costs. Okay, otherwise from the national governments and the subnational governments, or from the international, development agencies. Okay, so without such a variable on healthcare expenditure or health aid, still the conclusion seems not to be convincing enough. Okay, so secondly, I'm not sure whether it is also a good idea to include conflict intensity index, something like that, as the main explanatory variable. Because let's say in some countries, there are a lot of minor conflicts, and in some countries there are less number of conflicts, but with 1 or 2, strong conflicts within a year. It's that's why maybe an index could be something, more convincing compared to the number of conflicts within a cluster or within a country. And the conflict intensity index is, I mean, I'm not sure you can check the internet, because the exact name might not be the same, but I mean, the idea is the same. So there might be some institute, maybe Stockholm, Peace Research Institute, for example, they have some conflict intensity index for the countries globally. Okay, so certainly for control variables, we think that maybe birth orders, is it a good idea to, if the birth order is, it's included in the DHS data, okay? And also the family structure, for example, whether the children who live in a single parent family or whether children who are orphans, I mean, these variables, are they controlled or not? So also telecommunication channels, that's for literature from developed countries. I mean, like in America or in EU, for example, the internet use or or mobile phone use are positively associated with vaccination likelihood. Okay. Yes, but I'm not sure for the context in developing countries. Okay, so finally, there is still some potential gap in the research because the main explanatory variables do not have a clear policy implication. So, for example, if you also do the single to include a specific policy, okay, so still, the specific policy should be based on more specific, control variables. Yes. So the specific policy should be some policy instruments that the government, hold and have. Yes. And so there might be some, still also they may think of how to, how to argue for a, what should I say, how to argue for, for the linkage between the variables that are available and the specific, policy tools that government hold on hands. I mean, from different countries, of course. Okay. So yeah, local level analysis. I'm not sure. Do you have the share of vaccinated children at the regional level?
Roy, can you wrap up in 1 minute? Because
yes, this is the last slides. This is the final slides. Okay. So the regional level analysis may be another direction for the future of this research, or yes, potential policy implications, and also national and also regional policy level, because there are some African countries which are federal states. For example, Nigeria, more like a federal state, not a a single country. Okay, so yeah, maybe it's also think of to add some more relevant literature from, let's say, public health journals in order to make this paper more strong, in the next step. Yes. So thank you very much. Yes. So yes, I have finished.
Rui, thank you very much for very detailed analysis of the paper and very interesting suggestions. I think Olga will. Olga, you have actually a couple of minutes to respond, and we have some more questions. Actually, Achtem will direct them to you later. Yeah, and Olga, please.
Thank you. Thank you so much.
Yeah, thank you, Rui, for reading the paper on the short notice and providing your response. I know it has been a challenge. It's a long paper. So, yeah, so I appreciate actually the idea of looking at the multinomial longitude regression, looking at the no partial versus full vaccination. We haven't tried that. That could be an option to do. That's a good suggestion. We do not actually attempt to control for causal relationship because at this level, it's very hard to identify. For many countries, and we've been suggested by referees, kind of to reduce the reference to causal, although by comparing children within the same cluster who have been living under the same conditions, like thinking, basically thinking about like your city district, where children are exposed to the same type of policy, same access to, let's say, clinics, same level, relatively same level of education of population, similar level of conflict, similar level maybe of sanitation. And some children are, let's say, 3 years old, not exposed to conflict during their first year, and some children are 2 are exposed, when we plausibly can think that the conflict has a causal impact on their vaccination levels. I mean, that idea is kind of hard to think of, like, because you're thinking more like abstractly, but think about like the COVID exposure, right? And it will be studied all over. And you think about children who entered first grade at the time of COVID, right? Like children who, let's say, in Uzbekistan should be most likely 7 to 8 years old. And you can study that, like, and children who were 8 years old to 9 years old at the same time. And you can think that children who were exposed to formal schooling and children who were not exposed to formal schooling in their first year. And we live in the same community, and how did it impact their education? But here we're looking at the introduction of a cat. And it shows how these children are impacted, because like children technically we were exposed to the same conditions, same parents, same community characteristics. And the only thing that changed is that younger children were exposed during their critical formation year. I mean, that's an example that I'm giving is COVID, but like here you're talking about conflict when like vaccinations actually happen. So I do believe that our paper has causal implications, but kind of it's hard to convey it kind of broadly, right? Like so like we're looking here at the child level exposure. So I think like adding kind of healthcare expenditure at the national, subnational level may be an option, but well, honestly, I don't think it's gonna do much to the regression unless you do country level regression and kind of move to cross-country aggregate values and look at those, including also shares of children who are vaccinated regionally. Because like, regionally, you're looking at what children who were exposed to vaccination to children who were not exposed, right? And to an extent that we don't have much of an effect, especially in minor conflict, it shows that vaccination efforts have been substantial. I forgot to mention, but most of our kind of extended models were based on model 2, which includes only child characteristics. And we included most of the mother controls, fertility controls in particular, due to the referee suggestions, because of a concern that fertility may change during the conflict. And like, so like, what you identified related to your mother-terminated pregnancy sign, it actually doesn't transmit to other regressions like as we go along. My cat blocked all my notes by sitting on the paper.
I think
And birth order, it may be impacting, you know, like, I mean, yeah, we did it. I mean, we didn't discuss kind of a theoretical reason for including it, but birth order, you can think about like that one side that you may take greater care and be more careful with your first and second child, right? And it's like there is a lot of anecdotal evidence that you're very kind of hands-on with the first child. And well, like, and if you increase the number of children in the family, you are much more relaxed with children as we go along because you acquire experience and you know like but also you may lose track of things because your kind of attention is split.
I think, Olga, we are over time now.
Right.
And yeah, I think we have to conclude here, and we have some other questions. So as I mentioned, Achtem will send those questions to you by email. And yeah, Bahram, would you like to say something? Okay. So again, thank you very much, Olga, for a very interesting presentation and waking up early. Olga is joining from Atlanta, Georgia, East Coast of United States. And so it's very early there. And thank you very much, Rui, for very interesting discussion points and very good suggestions. And so, yeah, Bahram said he has no additional questions here. And yes, again, I would like to remind you, this webinar series are organized jointly by Westminster International University, University of Westminster, London, and International Food Policy Research Institute based in Washington, DC. So thank you for joining, and I hope you like the discussion and presentation, and it's very interesting topic, and especially immunization at this time around. And so
yeah, thank you so much for inviting me to give a talk. Appreciate an opportunity to talk about our research. And you know, it always helps kind of to summarize your ideas when you are talking through them. And appreciate Rui for your comments, and Camille John for moderating the talk, and Bahram for inviting me originally. Thank you.
Okay, thank you everyone. I think Kamal Jankram's network something happening. So visit our webpage conference.wiut.uz for for webinar presentations and recordings. Everything will be available there. Thank you again, Olga. Thank you again, Dr. Ridang. Thanks for our audience, and take care and stay healthy. Bye-bye.
Thank you.
Bye-bye.
Bye-bye. Have a great day. Bye.